Yeah, we're just ensuring the live stream is rolling. We do have live stream, however, in gallery mode. Okay, we're good now. At this time, will all sergeants please start their recordings? Recording to the PC underway.
Recording to the and so is the backup.
Thank you. Good afternoon and welcome to today's remote New York City Council hearing for the Committee on Hospitals. At this time, would all panelists please turn on their video for verification purposes? And to minimize disruptions, we ask you please place all electronic devices to vibrate or silent mode upon speaking. If you'd like to submit testimony, please send via email to testimony@council.nyc.gov. Again, that is testimony@council.nyc.gov. Thank you for your cooperation. Chair Narcisse, we are ready to begin.
Okay. Good afternoon, everyone. I'm Council Member Mercedes Narcisse, Chair of the Committee on Hospitals. I'd like to start by thanking my colleagues for being present today for this very important hearing. We are here today to discuss the current state of the primary care in New York City, with a focus on access to care through NYC hospitals. Before we begin, I'd like to acknowledge and recognize some of my colleagues members: CM Schulman, CM Barron, CM Joseph, Rita Joseph, CM Gutierrez, and CM Brooks Powers. Having access to primary care is associated with positive health outcomes, with primary care providers offering an unusual source of care, early detection and treatment of disease, chronic disease management, and preventive care. According to the Primary Care Development Corporation, persistent primary care barriers affecting health systems and communities alike are constantly associated with worse health outcomes and are often driven by long-standing social and economic inequities, including the effects of structural racism. This is seen in New York City, where council districts with a larger proportion of Black residents have fewer primary care providers per capita and higher rates of delayed or foregone care due to costs. Today, we plan to examine the inequitable access to primary care in New York City and how hospitals provide primary care, including via NYC Care. NYC Care is a healthcare access program through H&H that guarantees low-cost and no-cost services to New Yorkers who do not qualify or cannot afford health insurance based on federal guidelines. Just this month, NYC Care announced that they have enrolled their 100,000 member, and the program serves an incredibly diverse population. We really look forward to hearing more updates about the program from H&H and to dive into the ways H&H is addressing universal access to quality and culturally humble and competent primary care. In addition to NYC Care, H&H as well as other hospitals provide primary care via community healthcare centers and clinics. We must also discuss the impact of COVID-19 on access to primary care. People have delayed getting care for fear of COVID or because of other impacts of the pandemic, and have also unable to receive care due to the cancellation or delay of elective procedures. According to research by the Commonwealth Fund, the number of visits to ambulatory practices declined nearly 60% by April 2020. Further, the Centers of Disease Control reported by June 30th, 2020, an estimated 41% of American adults had delayed or avoided medical care, including routine care, 32%. These delays were not experienced equitably. Avoidance of urgent or emergency care was more prevalent among unpaid caregivers for adults, persons with underlying medical conditions, Black adults, Hispanic adults, young adults, and persons with disabilities. As individuals are engaging at a lesser frequency with healthcare providers, a larger number of people are falling through the cracks with untreated or poorly managed health concerns. For example, reports show that the number of patients being treated for major artery blockages dropped by 38%. And this is not because 1/3 of the population with artery blockage have gotten better while isolating at home. Physicians have stated that once they returned to seeing their patients in person, the proportion of care shifted from majority routine care to more urgent and post-acute care. To date, medical providers are concerned about delays in care. Recent reports by the Urban Institute have found that as of spring 2021, more than 1 in 10 adults chose to delay or not to seek at least one type of care in the previous 30 days due to concerns about coronavirus exposure, and nearly the same percentage of parents delayed or forwent care for their children for the same reason. Given all this information, we must discuss overall access to primary care. We particularly emphasize on communities most impacted by COVID. We must see if there are ways to improve access to primary care and build upon previous council discussion and work. For example, the City Council passed a law to codify and build upon NYC care by expanding services to include H&H facilities, FQHCs, and other nonprofit and private medical service providers. We look forward to hearing from our partners today, and we thank each of you for attending and are mindful of just how diligently you have worked during the pandemic. I also want to thank my colleagues again for joining our hearing today, as well as the committee staff for their work on this issue. Committee Counsel Habani Hauja, Policy Analyst M. Balkan, Dave Vem, and Finance Analyst Lauren Hunt. With that, I'm now going to turn it over to our Policy Analyst and Moderator for today, M. Balkan, and explain today's hearing procedure. And I would like to acknowledge CM Moya as well. Thank you for coming.
Thank you so much, Chair. Hi, everybody. My name is M. Balkan. My pronouns are they, them, and I am the Senior Policy Analyst to the Committee on Health and the Committee on Hospitals for the New York City Council. Before we begin, I want to remind everyone that you will be on mute until you are called on to testify, and then you will be unmuted by the host. I will be calling on panelists to testify, so please listen for your name to be called. I will be periodically announcing who the next panelist will be. For everyone testifying today, please note that there may be a few seconds of delay before you are unmuted, and we thank you in advance for your patience. All hearing participants should submit written testimony to testimony@council.nyc.gov. At today's hearing, the first panelist to give testimony will be representatives from the administration, followed by council member questions, and then members of the public will testify. Council members who have questions for a particular panelist should use the Zoom raise hand function, and I will call on you after the panelist has completed their testimony. So I will now call on members of the administration to testify. Testimony will be provided by Dr. Andrew Wallach, Ambulatory Care Chief Medical Officer. Additionally, the following representatives will be available for answering questions. Dr. Justin List, the Assistant VP of Ambulatory Care, as well as Dr. Jonathan Jimenez, the Interim Executive Director of NYC Care. Before we begin, I will administer the oath. So Dr. Wallach, Dr. List, and Dr. Jimenez, I will call on each of you individually for a response. Please raise your right hands. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee and to respond honestly to council member questions? Dr. Wallach.
I do.
Thank you. Dr. List.
I do.
Thank you. And Dr. Jimenez.
I do.
Great. Thank you all. So I'm now going to turn to Dr. Wallach, and you can begin your testimony whenever you're ready. Thank you.
Great. Good afternoon and thank you. Good afternoon, Chairwoman Narcisse and members of the Hospital Committee. I am Dr. Andrew Wallach, the Ambulatory Care Chief Medical Officer at New York City Health and Hospitals, known as H&H. I am joined, as you heard today, by my colleagues, Dr. Justin List, who's the Assistant Vice President of Ambulatory Care, and Dr. Jonathan Jimenez, who's the Interim Executive Director of NYC Care. Thank you very much for the opportunity to testify before you regarding the most essential part of healthcare, and that is indeed access to primary care. Primary care, as you know, is the first point of contact for all healthcare needs. Having a primary care doctor is the key to a person's overall sense of health. Regular visits help people get to know their doctor, making them more comfortable in talking about their health concerns, as well as making it easier to recognize any changes in their body in a timelier manner. Likewise, their doctor also gets to know the patient well and is able to ask the right questions and catch issues before they become more serious. With regular primary care, people do not have to rely on the emergency department, the emergency rooms, for routine healthcare services. Health and Hospitals offers high quality and affordable primary care services at all 11 acute care sites by way of its hospital-based primary care practices, as well as through our federally qualified health center known as Gotham Health. New York City's Health and Hospitals Gotham was formed in 2015 to address the primary care needs of families and individuals in their own neighborhoods. I am happy to report that it has 50 community health centers throughout all 5 boroughs today. At both our hospital-based primary care practices, as well as Gotham Health, we provide the following: routine checkups, preventative health screenings and immunizations for both children and adults, chronic disease management, including for things such as asthma, high blood pressure, heart disease, and diabetes, adolescent health services, behavioral health services. We also offer diagnostic imaging services, women's health and maternity care services, well baby and pediatric services, senior care and geriatric specialties, and importantly, help with implementing lifestyle changes, including things such as stopping smoking, helping those lose weight, and achieving other wellness goals, including exercise. To become a patient at New York City Health and Hospitals, New Yorkers can call us through our centralized contact center at 1-844-NYC-4NYC to schedule an appointment. Our contact center agents can access interpreters in 200+ languages and dialects as needed. And in fact, many of them themselves are multilingual. Patients can typically be seen by a primary care provider in our system within 1 to 2 weeks of their initial request. In 2019, Health and Hospitals teamed with New York City to set forth an ambitious plan to create a unique program that would guarantee primary care for New Yorkers without insurance. And that is called NYC Care. NYC Care was established to ensure that the 400,000+ New Yorkers without insurance, including those not eligible for insurance as they're undocumented, have direct access to H&H's physicians, pharmacies, mental health, and substance abuse services. NYC Care is now the biggest and most comprehensive health coverage program in the country, with over 100,000 active members enrolled. Unfortunately, during the surge of the COVID-19 pandemic in the spring of 2020, we clearly saw the negative effects that the pandemic had on the most vulnerable communities of this city, especially when it came to primary care. In particular, patients were fearful of seeking care at our medical facilities over concerns of contracting the virus. In addition, many of our own staff, clerks, nurses, advanced practice providers, and doctors were reassigned to care for patients with COVID-19 due to staffing shortages at the acute facilities. Together, this was a perfect storm. It negatively impacted preventative care, such as cancer screenings and immunizations, as well as chronic disease care. And indeed, we saw decreases in the quality metrics for these. The silver lining, of course, was that our strong ties to the communities that we served helped to quickly restore that trust in the medical system, allay fears, and ultimately allowed our patients to start to return to their medical homes for care. After that, they returned for COVID-19 vaccines and outpatient treatments such as monoclonal antibodies and oral antiviral medications such as Paxlovid. And as our patients returned, I'm happy to report that we saw a sharp improvement in those quality metrics. Lastly, in direct response to the changing landscape of the COVID-19 pandemic here in New York City, Health and Hospitals opened 3 new outpatient primary care Gotham sites. These sites are called the COVID-19 Centers of Excellence, or COE. The COEs provide comprehensive short as well as long-term care to support patients who are recovering from COVID-19 infection. The centers have been open to communities of color that have been hardest hit by the COVID-19 pandemic, again, here in our city: Bushwick, Brooklyn, Jackson Heights, Queens, and Tremont in the Bronx. It is the mission of Health and Hospitals to deliver high-quality services with compassion, dignity, respect for all, regardless of income, gender identity, or immigration status. Every single day, we work towards that mission and strive to continuously improve our services and the access to primary care within our system. Thank you again for the opportunity to testify before you all today. I look forward to your questions this afternoon. Thank you very much.
Thank you so much, Dr. Wallach. So I will now turn it over to questions from Chair Narcisse. Panels from the administration, please try to stay unmuted if possible during the question answer period. So Dr. Narcisse, please begin. Thank you.
Hi, I'm a nurse, so I'll take the doctor, but not the doctor. Thank you, Dr. Wallace. I appreciate it, and hearing from you is very important. And I have a few questions. In June 2020, the Committee on Hospitals had a hearing on hospital reopening. And during the hearing discussed the impact of COVID-19 had on access to care, including vaccinations, dental care, and cancer-related care. Can you share data on how COVID impacted healthcare services in H&H facilities since the first COVID crisis in 2020, including during the Omicron wave, and what particular healthcare services were most affected, including how primary care was affected? How has access to those services improved since 2020? How does current access compare with that of pre-COVID levels? Has H&H seen more individuals seeking primary care? I know it's a lot, but I know you can do it.
Thank you, Chair Narcisse, for those excellent questions, and always a pleasure to speak with a fellow clinician. Indeed, you are correct. New York City Health and Hospitals was no different than other hospital systems throughout the city, if not the country, with regard to decrease in visit levels. So for example, in calendar year 2020, we had 374,000 unique primary care patients that came to our system. I am happy to report that in calendar year 2021, 1 year later, we were able to increase that number from 374,000 to 424,000. So a nice increase, again, about showing that our patients are coming back and they feel safe. To your initial question about which services were hit the hardest, this was a really tough call for us back in March and April of 2020. It's not that long ago, but it seems like forever. We were dealing with a new virus that we were still learning about. In fact, today we are still learning about it 2 years later. That said, we made the conscious decision at H&H to maintain what we declared essential services for our patients. So to your point, for example, pediatric immunizations, we know that this is the backbone to pediatric health, and they are critical that they occur on schedule. So we kept pediatric immunizations open continuously throughout the pandemic. We created what was called immunization fast track visits for our youngest patients, where they literally would come in, they would get their immunizations, and we would get them out safely. And so I am happy to report that we never paused our immunizations for the pediatric population. Similarly, once COVID-19 vaccines became available, anytime a pediatric patient came to get their vaccine for COVID, we used that as an opportunity to look through their electronic medical record to see if they were behind on any other vaccines. And if so, we were able to co-administer those vaccines as well. And that is in fact the reason or the rationale that we decided to perform our pediatric immunizations for COVID-19 directly within our pediatric clinics, as opposed to a vaccine hub or super site. So those are just two examples of how we were able to maintain care. Now, in addition, some other essential services included our cancer care, right? Just because there is a pandemic, you can't say that to somebody who's expecting to get their chemotherapy and interrupt their treatment regimens. So again, even in March and April, during that first wave, which was so horrific to the citizens of New York City, we continued those services. We prioritized them. We made sure that our efforts went in to making sure that the experience and the treatment course was safe for those individuals coming to our facilities. Now, I will tell you, now that we are 2 years into this and we have been through several different waves, most recently being Omicron, as you mentioned, in December and January, I'm happy to report that we were much better situated to continue with routine primary care. We had lessons learned from the past 2 years. And one of those biggest lessons was our pivot to virtual care or telemedicine. And very early on in the pandemic, most of our telemedicine was through the actual telephone. And I'm happy to report that we saw a 50-fold increase in the use of virtual video visits during this last wave in December and January, which we believe is a higher quality visit. It gives you more detail. And so we were able to better weather, if you will, the fact that patients were concerned to come in during this latest wave. So my take home is we completely agree. There are essential services that were never interrupted in ambulatory care. And when we did interrupt routine primary care, we pivoted to using technology to help us to engage our patients to continue with their chronic disease management.
I want to say thank you. And before I go to the next question, I want to acknowledge that we're joined by my colleague, CM Rivera. Thank you for being here. The next question, how is the city addressing the continuing need to get more individuals back to primary and preventive care? How is the city doing this while remaining particularly mindful of communities disproportionately impacted, including those which you just mentioned, cancer treatment, individuals with disabilities and others? And what sort of long-term implications may this delay in care have on the health of New Yorkers?
Yeah, again, an excellent question, Chair Narcisse. And I would say that, you know, one of the silver linings, if you will, of this horrific pandemic that we have been living through is that we were able to see the infrastructure here in New York City of our healthcare system. And in particular, I want to point out our community-based organizations, which New York City Health and Hospitals has partnered with. And Dr. Jimenez can talk a little bit more specifically about NYC Care and its close relationships with 22 plus of these CBOs which are embedded in these very neighborhoods that you allude to, right? And we know that there's mistrust of the medical system. And so no one is better to improve that trust than those who are actually living in the community with their patients. And I would say the same for New York City Health and Hospitals, in particular with our Gotham Health sites, right? These are 50 neighborhood health centers that are scattered throughout all 5 boroughs. Our staff who work at these locations often come from the very communities where they work. And there is that trust level between the patients and the individuals who are working there. So that is of the utmost importance. Now, that said, we have our work cut out for us, right? We need to bring patients back into primary care. We need to let folks know that our clinics and our hospitals are safe and that it is important for them to continue to engage. So we've done this a couple of ways. Number one is through the partnerships of the CBOs. Number two, we've also partnered with other city agencies, including MOIA in particular. And I have to say, from my perspective, that is also another silver lining that I've personally had the opportunity to work with that amazing agency to help us get the word out, whether it's with the ethnic media, whether it was myself doing roundtable discussions about COVID and the importance of primary care. That has really been critical to get our message out where it needs to be received. Now, H&H itself has also launched very extensive media campaigns. I think everybody who's on the Zoom today has ridden the subway and seen our beautiful, media campaign that is colorful and is, again, speaking to the point and the importance of primary care. We've also used technology. Again, looking for a silver lining in a horrible, pandemic. We have a new electronic medical record that has an electronic patient portal. We now have the ability to direct message our patients who are a part of that. And I want to just take a moment to shout out and say that I'm very proud of my colleagues at H&H because this electronic portal that I refer to has been activated by over 70% of our patients. Not only is that a record for a safety net system, but it also beats most private healthcare systems throughout the United States. So we are well taking advantage of this ability to message to our patients. Now, in addition to that, not everybody has a MyChart account or feels comfortable going online. So we're also doing the old-fashioned way. I've been at H&H for 25 years. We're picking up the phone. We're calling our patients. Again, we have an electronic medical record that helps us identify those patients who are at highest risk or who haven't seen us. And so we are calling those patients back into care. And then lastly, intervention, which I think probably has the highest benefit, is we now have community health workers who are a part of our care teams. They're an essential part of our care teams. And they are literally going out into the communities and they are knocking on doors and they are sending that message to our patients. It is safe to come back and it is important to come back. So I would say through all of these different methods, we're trying to meet New Yorkers where they want to be met to see what works best for them and engage them back into primary care.
Thank you. Engagement is everything. I'm going to do a third question. And after that, I would like to have my colleagues involved as well, because we have a chair of health with us. Looking forward, how are we as a city looking ahead and building a more equitable healthcare infrastructure? How are we prioritizing social determinants of health? What other supports initiatives is H&H setting their sight on as continue to build more equitable New York City? NYC Care, Primary Care Development Corporation, PCDC, has studied the inequalities in primary care access and delivery amongst New Yorkers, which are largely driven by economics, including insurance coverage, reimbursement, and social determinants of health. Geographic, demographic, and socioeconomic characteristics impact where the primary care providers are located. For example, districts with a larger proportion of Black residents have fewer primary care providers per capita and higher rates of delayed or foregone care due to costs. Are there any efforts to expand H&H presence in these neighborhoods? Thank you.
Yeah, again, wonderful question and near and dear to my heart. as a primary care physician who practices, at Bellevue as part of our system, H&H has at its core value primary care, and specifically from our senior leadership down, from Dr. Katz down, and it really has been a sea change. We are continuously looking to see where healthcare services are needed throughout our city. We regularly review our community healthcare needs surveys to understand what services are not available in communities, and then how we can add those. So I know that, in fact, my colleagues have an upcoming meeting scheduled, I believe, with yourself and your team to specifically look at needs in your area. But again, this is something that we do across the board. So it is part of our regular work to see where those services are needed and how H&H can actually help fill those gaps to bring patients the services that they need to lead their healthiest life. So this is a high priority for us. It is an ongoing process. It's not just to say, for the next 6 months, we're going to do this, but rather this is something that we continuously do throughout our communities. And again, I do want to highlight that our Gotham Health neighborhood and community healthcare centers are embedded in many of these communities that you have just alluded to. And again, for us, that is really important to make sure that we're offering them high quality care and getting them connected to the hospitals as they need it.
Will the new local law expanding NYC Care to include FHQCs help?
Yeah.
How? And
Yeah.
how is H&H preparing for the implementation of the law? How
Yeah.
did the COVID-19 pandemic affect enrollment in NYC Care?
Again, great questions. And I would say NYC Care, I believe, has been a wonderful success story here in New York City. I'm very proud of my colleagues and the work that they have done to enroll, as we mentioned in my testimony, of over 100,000 new members of this particular program. Of note, 50 to 60,000 of that 100,000 are new to primary care, meaning they had previously not had a relationship with a primary care provider. And that is critical, as we've said, as step one in making sure that individuals stay well, throughout their years. Now, that said, H&H is very excited to continue our partnership with these CBOs, especially for those who already have PCPs. Again, as I said earlier, it is so critical that a patient feel comfortable with their PCP. And if they have one at a CBO, we would never want to disrupt that. But where we can come in and help is we can provide a lot of the specialty care for those patients that may not be available at those smaller neighborhood community health centers. So indeed, we very much are looking forward to a further expansion of this work that we've been doing to make our specialty care services even more available to more New Yorkers who have primary care providers at these CBOs, and whatever services they need, we are happy to help provide. So we look forward to this upcoming change that I believe is coming in the fall.
Thank you so much. You've been keeping up with all the questions. One more before I pass it on to my colleagues. NYC Care announced that they have enrolled their 100,000 members just this month. According to their press release, of the over 100,000 patients enrolled in NYC Care, 30 to 50% are newly connected to primary care. Once a patient is enrolled in NYC Care, how does H&H continue to ensure that they remain connected with healthcare services past their first appointment?
Again, so important, because as we've said, and as you know, as a clinician yourself, it is not just that first visit, right? It's about establishing that relationship and having a longitudinal care plan for individuals, even if they're healthy, right? We still want people to feel connected and have a PCP that knows them. So like all of our patients, and not just through NYC Care, but I would say for all of our primary care patients at H&H, they become part of our medical home. It is their family, if you will. And so there is a care team that surrounds that patient. That includes people such as the nurse, the doctor, the advanced practice provider. They're ones who will continue to engage in that individual in preventative care. And if we notice that a patient has not come back, we do active outreach. And this has been a real sea change. You know, as I mentioned, I've been here for 25 years. When I first started, if a patient didn't come between visits, I don't know what happened. But now we have powerful tools through our electronic medical record and registries for patients with chronic diseases. And we now track them. And if we haven't seen them in a while, we'll ping them through the portal if they have a MyChart portal account. If not, we'll call them on the phone. If they don't respond to the phone call, we'll send a community health worker out. But the goal is to make sure that these folks continue to engage in care. And we want them to know that they have a home with us. And we want them to look towards that rather than, okay, I've met Dr. Wallach once, but next week, if I have back pain, I'm going to go to the emergency department. I want them to call me rather than go to that emergency department. And so again, it really is a combined effort of the entire care team, of which the provider is just a part.
Thank you so much. I'm gonna pass it to Anne, and you can continue with the questioning with my colleagues. Thanks.
Yes, thanks so much. Thank you, Chair. So I will now call on council members in the order they have used the Zoom raise hand function. If you would like to ask a question and you have not yet used the Zoom raise hand function, please do so now. Council members, please keep your questions to 5 minutes. The Sergeant at Arms will keep a timer and will let you know when your time is up. You should begin once I have called on you, and the Sergeant will then cue you and say that you may begin. So that's when you can start. So I'm now going to call on council members in the order in which they have raised their hands. So starting with Councilmember Barron, followed by Councilmember Rivera, and then Councilmember Schulman. So Councilmember Barron, you may begin asking questions when you're ready.
Time starts now.
Well, thank you very much. The cordial exchange between the chair and yourself, Doctor, sounds nice and flowery, and you had nice rhetoric in terms of answering all the questions. No numbers, no facts. This is not about a time to just, answer questions in generalities and nice words. The bottom line is that we have a big disease in our neighborhoods and the nation, and especially as it relates to healthcare, and that disease is called racism. And we haven't found the cure to that yet. And the answer to the primary care opportunities in our community are dismally low. Our primary care is the emergency room. That's where most of our people go. And then most of our hospitals are reliant on Medicaid. And when you have 80% of the hospitals are relying on Medicaid and the more well-to-do communities rely on private insurance, you're going to have a problem when you have a state with a governor that talks about a Medicaid redesign team and then doesn't want to say cuts, so he'll say savings. And during the pandemic, he cut $2.5 billion from Medicaid and then wrote a book how great he was doing with the pandemic. What hypocrisy. So when you have that happening and your biggest problem is funding and how funding is allocated to the communities that are in the greatest of needs. We've seen during this pandemic that Black and brown people died the most, were affected the most, but yet a ship of 1,000 beds went to the white community. Yet the Javits Center in the white community was turned into a medical facility. Central Park in the white community was turned into a medical facility. We had to fight just to get PPE and generators. And in our hospitals to make sure we had the staffing, appropriate staffing. Health is the most serious issue in our neighborhoods. Even if you have a PhD, well-educated, and you ain't healthy, there's a problem. So I'm just concerned that we don't have a hearing on rhetoric and looking at some real numbers and smiling at each other and happy and saying things and but not looking at the real numbers in Bedford-Stuyvesant, the real numbers in East New York and Canarsie and Brownsville. And I see the Gotham centers, but their healthcare delivery is not like a hospital. You know, they have some stuff and it's needed. And then they're setting up urgent care facilities in some of our communities so they don't overdo in the emergency rooms. So we got to look at, when we look at voluntary hospitals, private hospitals, then we look at the HHC public hospitals and try to combine those things together to take care of our community that's suffering from high rates of everything. Before COVID, we were dying from high blood pressure, heart disease, lung, way before COVID. Because politically, our pre-existing economic condition of capitalistic oppression and racism, which makes the healthcare situation totally out of proportion. So give me some numbers on primary care in our communities, what they are now and your goals. Give me some numbers on how we're going to give our people access to quality healthcare services. You know, and most of them have Medicaid and they're cutting Medicaid, and then our seniors have to pay high costs for prescription drugs. We have a major, major problem, and we need to answer it with concrete numbers and goals to address these issues. Thank you.
Thank you very much, Councilmember Barron. I do appreciate your comments and agree completely. As I said early in my testimony, we did see an increase from 2020 to 2021 of 50,000 newly engaged patients within our system alone at H&H. A lot of that was specifically related to folks who would come to us for COVID-19 related services, whether that be testing or vaccines. And they realized that, you know, look, this is a good place that I can get my primary care as well. And so that was a net new of 50,000 unique patients. We continually do outreach efforts to make sure that patients know about what services are available within our system. I personally have worked with DFTA and have given several talks on topics not related to COVID, including diabetes and hypertension, again, to engage those members of the community and let them know those services are available at New York City Health and Hospitals. To your point about our Gotham sites, you are correct. They are not fully equipped like a hospital, but the advantage of our FQHC is that they are affiliated with our hospitals. And so if there is additional specialty care or a procedure that cannot be done at a Gotham site, they now have the ability to refer that patient into one of our acute hospitals now that we're on a shared electronic medical record platform. So we've definitely seen an improvement in that. As far as quality goes, that is, from my perspective as a clinician and the CMO for ambulatory care, the single most important thing when I go to sleep at night, to make sure that the care we are providing is of the highest quality. And I'm very proud to report that throughout the pandemic, when we were still being distracted by all things COVID, several of our sites, including in Queens, were recognized by national agencies, including the American Heart Association, for our work in blood pressure control, for our work in cancer screening, and particularly for vaccinations against HPV. So I agree completely with you. Have we gotten to where we need to be? Absolutely not. We still have a lot more work ahead of us, but we believe that primary care is that engine that will get us to where we need to go. But completely agree that there is still much work to do. We need to better engage in our communities. We need to make sure that our workforce at H&H reflects the communities that we serve, so that there is that level of trust between our patients and the healthcare system, because we're making up for past indiscretions.
Time expired.
Okay, thank you all so much. So we will now turn to our next council member. So Councilmember Rivera, you may begin when ready.
Time starts.
Thank you very much. Thank you to everyone for being here for your testimony. Of course, I want to congratulate the council member on her first hearing and for choosing such an important topic, access to primary care. Just a couple questions, and again, thank you to the administration for being here. Two things I want to touch on. First, I'll start with mental health. Can you speak more to how you measure outcomes for routine mental health screenings for primary care patients at New York City Health and Hospitals locations? And I guess the B part of that is, how does Health and Hospitals approach referrals for additional support when necessary?
Great. Thank you very much, Councilmember Rivera, for your questions that are always on point. Indeed, mental health, especially during the pandemic, as we know, is really critical to the overall health of our patients. And so within primary care, we have embedded routine screening for depression for every patient who comes to primary care. It's something called the PHQ-2. It's a 2-question screener. If it is positive, it triggers a 9-question screener. And based on those results and the evaluation by the provider, we can enroll patients who are depressed or have signs or risk of further depression in what we call a collaborative care program. When they are enrolled in our collaborative care program, which is our behavioral health colleagues that are co-located within the adult primary care clinics, we track these patients very closely. And some of the metrics we use to see how well they're doing is, number one, we continue to look at their PHQ scores to see if their depression is improving. We also look to see their engagement. Do they keep their appointments? Are we able to contact them? And then there's actually an objective scale that shows the improvement of one's score over time based on treatment. And that is something that we also track. So these patients are enrolled in our collaborative care program and tracked very closely. Now, depression is just one of many behavioral health issues, right, that adults are susceptible to. And so, in fact, we also now start screening for substance use disorder, whether that's alcohol and or drugs or tobacco. We also screen for anxiety as well. So again, all of these are hard baked into our primary care services at H&H. And if somebody screens positive, we work with our behavioral health colleagues to make sure those resources are available to the individual. In particular, with substance use disorder, which we know is its own pandemic throughout our country, even before COVID-19, we have established buprenorphine clinics within primary care. This is a powerful medication that helps people with opioid addictions to be able to maintain healthy lives and continuing not have to go to a methadone clinic every day, to get medication. And this has been incredibly successful to keep folks engaged and working and keep their addiction under control. So that's yet another example of how we've embedded that, which historically has been a behavioral health, issue within primary care services. Now, we're also very lucky, as you know, that H&H, if somebody needs additional services, we have that level of expertise from our behavioral health colleagues at H&H, which I think are perhaps the finest throughout New York City.
Thank you. I appreciate that. And just my last question is, how are we prioritizing primary and preventive care for pregnant people? In 2018, the city established a 5-year plan to reduce maternal deaths and life-threatening complications of childbirth among women of color. And part of this plan included a commitment to establish primary care interventions to identify women who are planning to have a child within 6 to 12 months. And providers will establish a care plan for women seeking to give birth within that timeline. What is the status of these primary care interventions in 2022? And thank you, Madam Chair, for the time.
Yeah, again, excellent question, Councilmember Rivera. Indeed, it is disconcerting to see those numbers that you just quoted. And in fact, primary care and routine planning is critical. So in fact, our women's health services providers, the obstetricians and gynecologists, we have worked together with them in primary care to talk about that. And in fact, again, within our electronic medical record, we now have a hardwired question to any woman of childbearing age, asking the question, do you think anytime in the next 12 months that you would consider getting pregnant? And if so, it then kind of takes you down an algorithm, if you will, to make sure that individual has counseling, that they're put on prenatal vitamins, if that's appropriate clinically at that time, and to start being, preventive rather than reactive down the road. So that has been a real success. And again, technology has been our friend to help facilitate that.
Time expired.
Thank you so much, Councilmember, and thank you, Dr. Wallach. We will now turn to Councilmember Schulman, but before we do, I just want to remind all council members that if you would like to ask a question and have not yet used the Zoom raise hand function, please do so. Councilmember Schulman, you may begin once you're queued.
Time starts.
Thank you very much. I want to thank Chair Narcisse on this very important and timely hearing, and also congratulate you on your first hearing as Chair of the Hospitals Committee. I want to talk about the connection to primary care, which I think is just very key for all New Yorkers. We're experiencing the worst public health crisis of our lifetime. And it's very much known that COVID particularly affected those with underlying health conditions, with comorbidities, and also people who are older. And so one of the things I want to talk about, my district in Queens, which takes in central Queens, is not traditionally considered underserved, but this district has one of the highest number of seniors in the city in terms of city council districts. And in addition, the seniors, the majority of seniors 65 and older who are on SNAP is much higher than the actual county of Queens. And so what I want to talk to you about, I don't have any public health entities here in my district. I have private hospitals, and people here go to urgent care for their health care and preventive and primary care pretty much. So I wanted to ask you if there's any thoughts given to expanding into areas, particularly where there are seniors and older people, of sort of the public health system moving into those areas, whether it's a health center or something like that, because my district, and I'm sure others, are just clamoring for that. So I wanted to ask you that.
Great, thank you, Councilmember Schulman. And I would say absolutely, our goal is to continuously look to see what healthcare services are needed throughout the city in the different neighborhoods and districts. And we would be happy to set up a meeting with your team to look specifically for your district. I will tell you, and I'm smiling because throughout the pandemic, I did do a couple of talks for seniors, including from folks in Queens, where they literally came to the center for folks, and then we did a Zoom. And I must tell you, the seniors kept me on the toes more than anybody else for any Zoom that I did throughout the pandemic. Their questions were on point, they were sharp, they were good, they were well informed. So anything we can do to support our seniors, you have my backing. So we were happy to set that up with you.
No, I appreciate that, because as you know, seniors also, it's difficult for them to ambulate and get around too. So for me to go to Elmhurst or Queens Hospital, yep, two equidistant facilities in my area, it would be difficult. So yeah, no, I look forward to that. Thank you very much.
Of course.
Great. Thank you so much, Councilmember Schulman. If you don't have any other questions,
Nope.
I now see that. Okay, great. Thanks. So we will now turn to the next council member. So Councilmember Gutierrez, you may begin once the sergeant cues you.
Time starts now.
Hi, thank you. Thank you, Chair Narcisse, for doing an amazing job. You're a great advocate, obviously. And thank you to my colleagues. My question, Dr. Wallach, is particularly about language access. I'm a fan of the NYC Care program. Woodhull is a hospital that serves predominantly the majority of my constituents. So my question is about the language access and outreach efforts. And it's really specific only because in the recent years, we've seen a growing population of Quechua speaking people that are migrating. And as I'm getting to know these families who are my neighbors, I'm learning that they are challenged in a lot of institutions, whether it be at their child's school or daycare centers, where, you know, because it wasn't a language that we've seen here in like 10, 15 years, it's very difficult for them. And so I'm just curious, like, if you can outline the specific languages, if Quechua is one of them, and if not, kind of like what is the process to integrate new languages in the future? Thank you.
Yeah, thank you, Councilmember Gutierrez, and really a wonderful question, and thank you for asking that. You know, in particular, one of the things I love about living and working in New York City is we are a melting pot of the entire world. And indeed, any and every language is spoken within our system. So we have a couple of approaches to making sure that patients are able to communicate effectively in their preferred language when they seek healthcare at New York City Health and Hospitals. So first and foremost, as I alluded to earlier, when we hire staff, that is something that's really important to us to make sure that our patients speak the same languages as our staff. So if staff have that ability, that is definitely something we look for in our hiring process. Now, unfortunately, that's not going to cover everything and for every dialect and every language, but it is something that we use. In addition to that, we have available in-person interpreters at all of our sites. We also rely on iPads, which is something using technology over the past year or two that we've added, where there is an iPad on a stand and there's a live person who's actually interpreting for the provider and the patient in real time. And then lastly, we have language line telephones. We contract with a certified vendor for medical interpretation that has over 200 languages available, including dialects and not commonly spoken languages. And so that has been very effective. I will turn to my colleague, Dr. Jimenez, to speak specifically a little bit about the NYC Care team and their outreach and any language capabilities or tools that they use to help.
Absolutely. We are currently working with 22 CBOs across the city and they have staff that speak over 30 different languages. And of course, as Dr. Wallach mentioned, we have all our materials translated into the sort of this typical standard 13 languages, but we've also, at the request of some CBOs, translated materials into other languages such as Khmer or Lao, which were needed to reach sort of the hardest to reach population. So certainly we can discuss whether the CBOs that are working in your district, if they're encountering the need for materials in that broader Quechua or any other indigenous language, we can try to translate some of our materials to make sure that we reach that community as well.
Thank you, Dr. Jimenez. If I may, I would add one other comment. I know I talked a lot this afternoon about our electronic medical record. And I would just say, it is the one we use is called Epic. It has the largest market share here in the United States. But one of the things that we were most amazed about is its limitations in other languages other than English. And so in fact, New York City Health and Hospitals has been working with Epic Wisconsin, which is their central office, if you will, to make sure that they update their system so that it is available in additional languages to meet the needs of our patients. And I'm happy to report, based on our advocacy / nagging to Epic Wisconsin, we went live this past week with Simple Chinese on Epic on our MyChart. And that is just a huge step forward. And we look forward to those continued conversations with Epic Wisconsin to make sure they meet the needs of our patients.
Thank you. I am a personal fan of MyChart, so I would love to see it expanded. And if you could get back to me on the Quechua component, just because it is a specific dialect. We're seeing a huge population in parts of Bushwick and Bridgewood, parts of the South Bronx as well. So I would appreciate that. Thank you so much.
Yeah, and I'm happy to tell you that is available on our language line. Because in fact, I've had patients myself who speak that particular dialect and was able to connect with a certified medical interpreter through our language line. So absolutely.
I love it.
Time expired.
Okay. Okay, thank you so much, council members, Barron, Gutierrez, Rivera, Schulman. So we will now turn back to the chair for additional questions. So Chair Narcisse, you may start asking your questions whenever you're ready.
Thank you, Dr. Wallach. And I have to say thank you for putting EPIC, because as a nurse working for 30 years, I know how difficult that can be. In the filing system, the medical filing system, so now I have to follow up on that one. Is that include doctors and nurses' notes?
It does. The nice thing about Epic, it is full thickness. It is all of our documentation in one place. And if a patient of mine goes to, say, Woodhull and Councilmember Gutierrez's district, I will have full access to all of that information.
I love it. I love it, because that's one of the problems I used to have practicing in the ER. Back to NYC Care. How is the city working to ensure that communities with, like my colleague Judah just mentioned, with the language access? I know we talk about Spanish, I know it's very popular, Creole speaking, different languages, dialect that's not currently speaking. How do we relate to that in the communities to create that access that we need?
Yeah, great question. So I will start and then again pass it off to my colleague, Dr. Jimenez. But just to say again, all of our communications that we do at New York City Health and Hospitals, we translate into the top 13 most commonly spoken languages in our city. That is our standard at a minimum. And so that is done automatically. Now, again, if and when patients are enrolled in NYC Care and their preferred language is one that is not commonly spoken, again, we do have the ability to use our language line or to use these iPad video interpreters if they want to see a live person to help. So we definitely have all of those modalities. I will turn to Dr. Jimenez to see if there are additional methods. I know that your outreach team also have access to these language, interpreter services, but we'll defer to you.
Yes, absolutely. I think we have our staff through the CBOs that we've contracted with, as I said, speak over 30 different languages, including absolutely Haitian Creole. And then we also translated the materials for outreach into those languages and make sure, I think to, the point that Dr. Wallach has brought up, that people know that when they approach one of our facilities, they can ask for telephonic interpretation and expect that there will be interpretation available if there isn't already a staff member, a provider that speaks the language, which is also very common. We have a very diverse staff across our facilities. So, and with any other languages that we may encounter, we also try to make sure that we make materials available if that's a common gap that we're encountering during outreach.
Thank you. What outreach do you do when other communities traditionally marginalized within society and the healthcare system, such as disability, community and lesbian, gay, bisexual, queer, questioning, transgender, gender non-conforming, and non-binary communities?
Thank you very much for that question. Again, I want to emphasize that New York City Health and Hospitals provides high quality care to all New Yorkers, period. And that is something I am very proud of as a primary care physician within the system. I can tell you that we have worked historically, myself included, with ICS to look specifically at patients who have disabilities. We have used them to come into our site to make sure that even things such as our examination tables are appropriate, right, and meet the needs of those with disabilities. I'm going to defer to my colleague, Dr. Justin List, in a moment to talk about LGBTQ plus care, but I am happy to say that we have established in our system a series of what we call Pride clinics, which are geared specifically to that community. And the goal is to create a welcoming, safe environment for members of that community where they feel like they can come and express their particular medical needs, their social needs, their concerns. I did fail to mention earlier, several of the council members have mentioned kind of social determinants of health, right? And I just want to say out loud, that has also been hardwired into our primary care services, where we screen patients for food insecurity, for housing insecurity, for domestic violence. We recognize that all of those elements have such a critical impact on one's health. I like to say that going to medical school was the easy part, right? Anybody can treat diabetes or know what meds to use for high blood pressure. But it's like, how do you do that when somebody is worried they're going to be evicted from their apartment or they don't have enough money? Do they pay for their medications? Do they pay for food for their children? And so this is something that's very important to us at H&H and really impacts all of our patients that we provide care to. And we have the resources, thankfully, through our social workers and others to help these patients. But in particular, Justin, do you want to talk a little bit more about the amazing work that we're doing with the LGBTQ plus community?
Yeah, thank you, Dr. Wallach, for the opportunity to talk about that. Yes, so as Dr. Wallach mentioned, we do have 6 Pride Health Centers across Bronx, Brooklyn, and Manhattan that provide responsive, affirming care to the LGBT community and non-conforming, non-binary individuals as well. Our EMR allows for preferred pronouns and also for preferred names, which is something that I think Health and Hospitals does a very good job compared to peer organizations in New York City and even nationally. Additionally, Metropolitan Hospital has gender affirming surgery for transgender and gender non-conforming individuals. I can speak, as a primary care provider who has practiced at our Judson Health Center clinic. Patients come in and the signage, even the way the waiting room is constructed, is incredibly welcoming to people who would identify as part of a marginalized community with regards to sexual orientation. Even pronoun pins are right there at the door when you walk in. And one of the nice things about the integrated care at many of the sites, and especially the Pride Health Centers, is there's often the opportunity to do a warm handoff to a social worker or to another behavioral health provider, so that that integrated care that Dr. Wallach talked about earlier really meets the patients right at the front door. And our customer service training, again, which is true across all of Health and Hospitals, is especially cognizant at our Pride Health Centers, from the security officer at the front door to the clerk and the rest of the team.
Thank you, Dr. List.
Thank you. H&H previously reported that the number of billable virtual visits increased from 500 in January 2020 to almost 57,000 in the first 3 weeks of the pandemic, and 235,000 by June 2020. The latest announcement on NYC Care also stated that more than 76,000 telehealth appointments were scheduled for members. Dr. Welsh, you mentioned earlier, but to follow up, can you discuss the shift to telehealth medicine? What are some of the pros and cons of this provision of healthcare?
Absolutely. And if you will, Chair Narcisse, I'm happy to report I have updated numbers for you, and just for the rest of the council to know that back in March and April of 2020, we literally did a handful of televisits, prior to the pandemic here in New York City. We literally turned on our telehealth services overnight, and it has been a journey over the course of the past 2 years. I am happy to report this afternoon that we have now successfully completed well over 1 million telehealth visits for our patients. And as I alluded to earlier, the majority of those were telephone-based virtual visits back in early 2020, even throughout the later part of 2020. But we've now made that transition that more than half of the televisits that we are currently doing are being done as a video televisit. This is a direct result of some technical improvements that we've made. We've contracted with a new vendor to provide the platform for that video. It is much easier for the patients as well as for the docs, in that you can access it from a smartphone, you can access it from a tablet, from a computer. It's pretty simple. You'll get a text, that the provider is ready for you. It's very user-friendly. So that has really helped us be able to make that transformation from telephone televisits to video visits, which is really wonderful. In addition, what I would say is telemedicine is here to stay. This is something that even pre-pandemic, we were starting to get our toes wet, if you will, in the water, and literally had to turn it on overnight because of the pandemic. But one of the advantages, one of the many advantages of using virtual care is that number one, it's convenient to the patient, right? We've shown very clearly that our no-show rates for patients who have virtual visits are typically less than 10%. That is different than our no-show rates for in-person visits, which can be as high as 20%. So we know it improves, the connection to care. And so that is really important to us. In addition, there are certain things that lead themselves much more appropriately to virtual visits, right? Things like if you have a rash, if you woke up with a sore throat, it obviates the need for the patient to have to travel and come to a clinic. There is a lot that we can do using that video platform. And I will add, if I may, that the video platform that we chose at H&H is state-of-the-art in that it incorporates interpreter services directly. I will tell you prior to that, including my colleagues at some fancy academic institutions here in the city, have to kind of jerry-rig their cell phone next to the computer to get an interpreter. And now with our platform that we chose, it directly incorporates interpretive services. So for us, this has been a real win. It is here to stay. If you were to ask me, my guess is that in primary care, about 80% of our visits probably will be in person, and approximately 20% would be virtual as we move forward. But again, patients like it, it's convenient, it decreases our no-show rate, and it's in a very effective way. It is a very effective way to provide care to patients. And so we are very pleased that this is now part of our armamentarium.
Thank you so much. Still have a concern about how we're gonna integrate the seniors without access, especially the phone, if we can get them with CBOs that can help them to make their appointment, and as well when it's time for their appointment, they have someone that can guide them and they can interact freely with their primary care. So that's a little side note that I have in mind that while you were talking about how telemedicine is here to stay, which I believe as well.
And Chair Narcisse, I'm sorry, there was a little bit of static. Did you say specific to seniors?
The seniors, the homebound and the seniors, we can make it more accessible to them through telemedicine, not doing it on their little telephone, but to engage CBOs, how they can make appointment and incorporate that. In your testimony, you stated that cancer treatment was maintained as essential services, but how about screening? Unfortunately, since the drastic decline in rates of cancer screening during the height of the pandemic in 2020, rates have not risen to pre-COVID levels. For example, in December 2021, studies shown that colonoscopies decreased by 45% in 2020, and prostate exam decreased by nearly 30%. In all, new cancer diagnosis decreased from 13 to 23%, not because there were less cancer, but because there are more people living with the disease and not knowing. Delaying a screening can mean delaying the crucial moments of catching cancer before someone becomes symptomatic. Has H&H seen a drop in cancer screenings as well? How is H&H working to ensure that patients are getting cancer screenings?
Yeah, thank you very much for that, Chair. Indeed, you are correct. And this is one of the negative impacts, if you will, certainly as a direct result of COVID-19 and the pandemic. I would add to that unfortunate list that you just said, I would also specifically point out breast cancer screening for women with mammograms. Indeed, we know very much so that women were concerned and frightened to come to our facilities throughout the pandemic to get their mammogram for fear of getting infected with COVID-19. So you are correct. We saw similar experiences with everything that you just mentioned at H&H. So a couple of things that we are doing to try to get caught up, if you will. Number one, during the pandemic, for those who were needing screening for colorectal cancer, which typically is done by colonoscopy, very early on, we pivoted to mailing patients at home stool test kits. These are little cards that they can complete, putting some stool on it, and then they can actually mail it back. And I would say this is a real success story, because I know I'm looking at Dr. List, who this is a particular interest of his with cancer and cancer screenings. And we've been talking about this for quite some time, Justin, right? Even before the pandemic. And we were able to actually turn this on and have the ability for patients to mail in those results so that they would not have a delay in their colorectal cancer screening. So I was really proud of those efforts. I don't have mammogram machines that I can send to someone's home. So that, unfortunately, we did see a slight decrease. But what we are doing now for that is we are doing, again, active outreach. And again, it comes back to our electronic medical record. There is a module in there for each patient that's called health maintenance. And it lets us know when routine cancer screenings or immunizations are due or overdue. And there's the ability for us to send reminders to those women, in the case of breast cancer screening, that they are overdue and we need to bring them back into care. So all that to say, where we could pivot to alternative means of screening, like in colorectal cancer, or even in prostate cancer, where we could order a blood test, a PSA as a potential marker for screening, we're now calling patients back into care to get them caught up.
Thank you. You've been amazing. So I would like to pass it to Em for some of my colleagues if they have any questions.
Thank you so much, Chair. So we will now turn to a second round of questions for council members. I would just like to remind council members again, if you have a question, to please use the Zoom raise hand function now. Once I call on you, the sergeant will cue you and you will have 3 minutes to provide more questions. So Councilmember Schulman, I see that your hand is raised. So once you're cued, you can go ahead and ask a second round. Thanks.
Time starts.
Thank you. So, Dr. Wallach, I wanted to say to you about cancer screenings. I actually, and people know this, I was diagnosed with breast cancer during COVID, and it was during a regular mammogram screening. So it's so important. And I know that I'm cancer-free. I'm actually going for my second 6-month mammogram next week. But it's very important. But I know a lot of women that didn't go, that didn't want to go. So we do have to catch up. So I thank you for that. I also, the question I have is about the Pride clinics. I actually worked at Woodhull Hospital for 10 years and worked with H&H and other capacities as well. I'm an out lesbian and one of 4 queer women who are members of the city council. And thank you, Chair Narcisse, for bringing this up, the LGBTQ issue. I was at Woodhull when they put together started putting together the Pride clinics at H&H. So, and I'm glad that we have them and everything else. And I was also part of the HRC whole process and everything else. But a lot of us in the LGBTQ community are concerned that when you set up these clinics, it means other folks in the hospital, other medical providers don't have to serve our population. So I just wanted to bring up and make sure that other providers, because I will tell you, while I was at Woodhull, which was from about 2007 to 2017, I did incur some issues with some medical providers around not wanting to work with the community. So I just want to ask how you're making sure that if people don't go to that particular clinic, that members of the community are being taken care of.
Yeah, great. Thank you very much, Councilmember Schulman, for that question. And most importantly, I'm glad to hear that you got screened and you were a success story, that you were doing well. So I'm very pleased. Thank you for sharing that. I will say to you, our Pride clinics, and and I'll defer to Dr. List a little bit more, but our Pride clinics are available to members of the LGBT community, right? Just because you're a member of that community, however, does not mean that you have to go to the Pride clinic for your primary care. I'm an out gay man in my practice. I'm not part of Pride. I have many of my patients who identify as LGBTQ+, and I feel like they get high quality care. Granted, I'm a little biased. But we have that option, and it really is quite honestly about the patient. It is their choice where they're going to feel most comfortable in seeking their care. Now, to your point, though, about the remainder of the staff, and I would say it's not just providers. I'd say it's full thickness, as Justin momentarily Again, literally, it's from the person who checks you in or the security guard who you see when you enter the facility. And so towards that end, H&H requires annual competency in LGBTQ plus, as well as cultural competency and cultural humility, as well as part of our foundation. But Justin, do you want to add anything to that?
Yeah, so thank you, Councilmember Schulman. Also, as an out gay man, I would say, I think we create the Pride Center for people to bring their stories, where the Pride Center, given their larger stories, might be the safer place to go. I think to Dr. Wallach's point, efforts around diversity, equity, inclusion from health and hospitals, there are a number of online trainings. Online trainings really prime the conversation, though. They're not necessarily the end of the spectrum of how you get someone in the journey. And I think one of the amazing things about working in health and hospitals is that we as a workforce bring our religious, historical, cultural traditions. One of the things that each of us do on a daily basis is let people know that regardless of their beliefs, everyone deserves to be treated with dignity, with equality and care, and that you can have your beliefs in a diverse society and a diverse workforce and provide people a place and an opportunity to feel safe and cared for, just like Dr. Wallach mentioned. And that is a focus across the health system. And it's a work in progress, just like it is across society right now too.
When I had, so when I was at Woodhull, one of the struggles I had, and Dr. Wallach, you brought up the competencies that people have to take. My struggle as an employee was some of the competencies that you took, you had to actually sign that you took them and they were mandatory and all that. Is this now, LGBTQ was not at the time. Is it now mandatory to do this? Okay.
Time expired.
It is, and just to say, you have to take a quiz at the end and pass, not just sign that you took it.
Okay. Thank you. It's progress.
Thank you, Councilmember Schulman. So I don't see any other hands raised, so I will now turn it over back to the chair to make some remarks.
Hi, thank you, Anne, and thank you to all my colleagues. I appreciate you. Without you, it will not be possible for all of you to be here. I see Schulman still here. Thank you. Miss CM Rivera, I can see you. And Gutierrez, I see you. Thank you so much. And who I'm missing, Rita. Thank you, CM Rita. Yes, Rita, I see Rita. I see CM Barron, thank you. And all the great questions. And most importantly, I have to say thank you, Dr. Wallace, for being here, for supporting this. This is how we can make changes. As a nurse for over 30 years working in the emergency room at Elmhurst Hospital, I appreciate the progress in healthcare. And I'm excited where we can have equity across the board to make sure we serve everyone, and everyone deserves quality healthcare. It should not be based on economic status, gender, or socioeconomic, none of that. It should be a right. Healthcare should be a right, period. Everybody should have quality healthcare, and especially when we're talking about a city like New York City. So I'm here to serve. So thank you. And Dr. Justin List, thank you. And Dr. Jonathan Jimenez, thank you. And the whole team of Senior Director of NYC Care. I appreciate you. So I'm gonna turn it back to Anne. Thank you.
Thank you, Chair, and thanks again to members of the administration. We have now concluded the administration's testimony, and we will turn to public testimony. So I'd like to remind everyone that we will be calling on individuals one by one to testify. Each panelist will be given 3 minutes to speak. For panelists, after I call your name, a member of our staff will unmute you. There may be a few seconds of delay before you are unmuted, and we thank you in advance for your patience. Please wait a brief moment for the Sergeant at Arms to announce that you may begin before starting your testimony. Council members who have questions for a particular panelist should use the raise hand function in Zoom, and I will call on you after the panel has completed their testimony in the order in which you have raised your hand. So I would like to now welcome Carla Nelson from Greater New York Hospital Association to testify. So So Carla, you may begin when ready once you hear the sergeant cue you. Thank you.
Time starts.
Good afternoon, Chair Narcisse and members of the Committee on Hospitals. I'm Associate Vice President for Ambulatory Care and Population Health at the Greater New York Hospital Association, and I really appreciate the opportunity to comment on this very important topic. My testimony today focuses on the tremendous amount of primary care provided by New York City hospitals and their efforts to address access, social determinants of health, and health equity. Greater New York members in New York City, H&H and the voluntaries included, have robust ambulatory care networks that provide millions of visits annually and serve a significant number of Medicaid beneficiaries. 8.3 million visits were provided in 2019 by these entities and 6.7 million in 2020. There's a notable decrease between the years that is attributable to the COVID-19 pandemic, where hospitals had to expand their inpatient capacity very dramatically and defer services, unfortunately, to be able to meet the immediate needs. When the first wave of the pandemic ended, hospital primary care departments conducted significant outreach to ensure that patients returned to care, and we complemented that with our own significant outreach campaign at Greater New York. The pandemic spurred rapid development of telehealth infrastructure and an unprecedented volume of phone and video visits, as you heard from Dr. Wallach. And now telehealth is embedded in the fibers of care delivery. And it's particularly helpful for patients with transportation challenges or other hardships or responsibilities that can make travel to an appointment difficult. Most hospital-based primary care practices in New York City and New York State are recognized as patient-centered medical homes. You heard Dr. Wallach talk about being medical homes, and the patient-centered medical home designation is done by an independent national organization. Recognized PCMHs, patient-centered medical homes, must demonstrate that they meet rigorous criteria in several areas. These include things like same-day appointments, continuity for their patients, language access, and cultural competency and humility. PCMH adoption has been strongly encouraged by the New York State Department of Health, and as a result, New York has nearly 2,400 patient-centered medical homes. That's 20% of the country's total PCMHs and more than any other state in the country. An important component of comprehensive primary care is access to specialty care. New York City hospital ambulatory care departments accept referrals not only from their own primary care departments, but from community health centers and small community practices. Many Greater New York members are adopting technology and other operational solutions to be able to ensure timely appointments to these services and then return those patients back to primary care. In addition to specialty referrals, hospital primary care is incorporating social needs referrals to address the social determinants of health. Many are asking patients about social needs at their appointments and then referring patients when needed to places like food pantries, housing assistance programs, legal assistance, and other social services. To facilitate referrals, many hospitals use Greater New York's tool HITE, or Health Information Tool for Empowerment, which is a publicly available online resource directory that lists more than 6,000 health and social services in New York City, Long Island, and Westchester. Hospitals are also working to improve race and ethnicity data collection, which will allow them to identify and address specific inequities in care through provider and staff trainings, quality improvement, and their outreach and engagement efforts. While Greater New York members work to ensure adequate and timely primary care access for all, they acknowledge the ongoing work necessary to provide equitable care and eliminate health disparities. Thank you again for the opportunity to testify today, and I'm happy to answer any questions that you have.
Oh, thank you so much. We're going very fast today, huh? I appreciate that. So do all voluntary hospitals have community clinics? Where can we find this information?
Many of the hospitals do have clinics that are located in the communities. Others have them located within the hospital's four walls. They can be located on hospital websites. HITE, which is the website that I mentioned before that Greater New York oversees. The web address is hitesite.org, HITESITE.org. Also does list locations of not just the hospital-based practices that are within the hospitals, outside in the communities, and also community health centers. So those are just some examples of some places where those locations can be found.
do hospitals do outreach? Your hospital do outreach to the communities most in need regarding the availability of primary care?
They do. Hospitals outreach to their existing patients, and I believe that they make their services known to the communities, in particular their primary care services. Yes.
Mhm. All right. I have a next question. I'm not going to keep you long. How are we prioritizing social determinants of health in your system?
This is such an important question, Chair, and the hospitals are doing a lot of work in this area. I mentioned that very quickly, apparently, I mentioned that the hospitals are doing social needs screening, and we're seeing this more and more in the primary care settings where a patient will come to their appointment and they may receive either a paper screener or meet with a community health worker or a nurse that will review a set of questions with them about their different social needs. And that is used for a number of things. Patients may be, like I said before, referred to social service organizations and community-based organizations. Many of the hospitals are developing partnerships with CBOs to be able to have really tight referral relationships. Also, that data is helping to inform care planning. You might change a medication if a person does not have access to a refrigerator, for example, as you know much better than I, being a clinician. So that's just one example. And also the data that's being collected is helping to inform the way that hospitals might advocate for resources in their communities or develop things within their own footprint. So for example, some hospitals were able to open up a food pantry located right there on site to be able to help a patient in need right there in the moment. And some have partnered with community-based organizations to do things that are similar. Some may have helped with transportation to appointments, so a free Lyft or an Uber. And those are just a few examples, but there are really a lot of efforts taking place in this area.
I'm loving it. Food pantry, right there.
Right there.
Uber, nice. Thank you. How voluntary hospitals have seen COVID impact access to primary care and preventive care?
I think the themes here are very similar to what you heard from Dr. Wallach, in that they did have to defer services. They did have to reach out to patients and make sure that they understood that it was safe to come back into care. Telehealth is a big component here. It does provide a way for patients to reach their providers, and the volume is, it has leveled out in some ways. We saw a lot more telehealth volume during the first wave of the pandemic, but now it's really being used as another care modality to be able to reach patients, and it can address issues like a patient might not be sure whether they're ready to come back into the facility. And it's also another opportunity to ensure that patients know it is safe to come back. The hospitals are taking significant safety measures, offering vaccines and other treatments also, and having those very important discussions with their patients.
I thank you so much. I appreciate your time. And I'm going to turn it back to Em.
Thank you, Chair. As a reminder, if any council members have any questions, please use the Zoom raise hand function now, and I will call on you in the order in which you raise your hand. Okay, so seeing none, thank you so much for your testimony. We will now turn to our second and final panel. So I would now like to welcome Rose Duhan, followed by Francine Cutler, and then Erin Verrier. So we will start with Rose Duhan, and you may begin once the sergeant cues you.
Time starts.
Thank you, Chair Narcisse and the Committee on Hospitals for the opportunity to testify this afternoon regarding access to primary care in New York City. My name is Rose Duhan, and I'm the President and CEO of the Community Healthcare Association of New York State, or CHCANYS. We represent all of New York's federally qualified health centers, commonly referred to as community health centers, which includes Gotham and 37 other organizations. Our member health centers provide comprehensive physical, dental, and behavioral health services to anyone, regardless of insurance, immigration status, or ability to pay. Community health centers across the city create a reliable network of primary care throughout the city. Across New York City, these 38 health center organizations serve 1.2 million patients at 490 sites, located in the communities hardest hit by COVID-19. Over 93% of New York City health center patients are low income. 83% are Black, Indigenous, and other people of color, and 12% are uninsured. Community health centers have played a critical role in ensuring access to COVID-19 testing, treatment, and vaccination in medically underserved communities. Throughout the pandemic, health centers have been a critical access point to testing, vaccinations, and ongoing care in their communities. I'd like to highlight 3 key areas where support is needed to ensure the sustainability and expansion of primary care. We are asking the council to advocate for state-level payment policies that encourage telehealth expansion. As mentioned by Dr. Wallach, telehealth is here to stay, and telehealth has proven to be one of the most promising tools in increasing access and help to reduce no-show rates, especially for behavioral health services. Behavioral health services are well suited to telephonic care, not requiring special technology, broadband access, or a specific location for patient or provider. A survey of Chickani's members found that nearly 60% of behavioral health visits are still occurring remotely. The flexibility to provide visits remotely has enhanced community health centers' ability to attract behavioral health providers, as well as other needed health professionals. The majority of patients continue to be seen in person, by preference and by necessity. Among all visits at community health centers, about 75% are in person and 25% are occurring via telehealth. Community health centers continue to incur costs associated with operational and maintenance of their physical sites, infrastructure required to deliver healthcare, and staffing costs, regardless of the modality or provider and patient location. Chickani's hopes that the New York City Council will continue to champion the telehealth program. I'd also like to mention the New York City Care program, which has been discussed. We are excited about the expansion of the program that was approved by the council and urge the council to support funding for community health centers to be included in the New York City Care program. Finally, we are asking the council to continue to advocate for a full repeal of the state's proposal to carve the pharmacy benefit out of managed care. Last year, the council adopted a resolution calling on the state legislature to pass and the governor to sign legislation to protect New York State safety net providers by repealing the Medicaid pharmacy carve-out.
Time.
We're asking the council to do so again. We look forward to a close partnership with the newly elected council on ways to improve access to primary care at community health centers. Thank you, and I'm happy to take any questions.
Thank you so much for your testimony. We will have questions at the end of the panel. Unless Chair, did you want to chime in now?
No, I was just going to ask it, but you can go on.
Okay. Okay, great. So we will continue with the panel and then we'll have questions. So we will now turn to our next panelists. So Francine Cutler, you may begin once the sergeant cues you.
Time starts now. You are muted.
I got it. Can you hear me now?
Yes, we hear you.
Great. Good afternoon. My name is Francine Cutler, health educator and outreach worker at the Brownsville Multi-Service Family Health and Wellness Centers in Brooklyn. I am also a delegate with 1199 SCIU. I appreciate the opportunity to speak to the Committee on Hospitals about access to primary care because at BMS, we are totally focused on providing care in the community. BMS is a fairly qualified health center in Brooklyn, New York, with 6 clinical locations serving over 18,000 patients. Our patients are low income, most receive Medicaid services, many have no access to insurance, and all are ethnic and racial minorities. This afternoon, I would like to talk briefly about the work we do outside the clinical settings and in the community, such as my own work as a health educator and outreach worker, and our work with the community health navigators. BMS community health navigators are our eyes and ears in the communities we serve. The navigators work with some of the most hard-to-reach populations that suffer from a variety of chronic illnesses and lack of access to services. Our navigators know the community, and we often recruit leaders who are respected in their communities and provide them with the training and resources they need to overcome barriers to care for and connect people to health and other services. We know that most people with chronic diseases are not going to a doctor or clinic on a regular basis. My own work as a health educator and outreach worker is also part of how we reach into the community. Every day, my job is to go into the community and promote better health, connect people to the services we provide, and look for more ways to meet people where they are so I can start a conversation about how to improve their lives. One of the projects I'm most proud of is our Reach Out and Read literacy work. These are opportunities during clinic visits or a pop-up event where I start off by offering books to individuals, and from there talk about anything else that they may need, such as food, clothing, beds, housing, and of course, access to health care. In 2019, I helped distribute over 5,000 books through our BMS Books for All program, and every one of these books is an opportunity to connect someone with additional services. A good example of this happened recently when I met a single parent of 5 at a pop-up event and found out she was in desperate need of food. I was able to use my connections in the community to first provide her family with needed food. From there, I was able to deliver some new beds for her children, and finally, we followed up with much needed medical care. This is how I can reach into the community. I start with the offer of a book and then use this as an opening to find out more about the person and look for other needs and hopefully get them connected to BMS so we can begin to integrate them into our healthcare programs. But all this work requires resources. Many of the people our navigators work with are not able to easily make it to a clinic, so telehealth becomes critical to connecting these patients with providers. During COVID, we learned how valuable telehealth is to provide access to care when people cannot get to a clinic. Our navigators can make these visits possible with patients who may not have access to technology, but this must be funded. Whether it is in person, over the phone, or with a video, a provider's visit all takes the same amount of time and resources, so we must make sure they are paid equally. We also need to fully fund the primary care services and patient navigation program that the City Council passed last year. We need to encourage the mayor to make this a budget priority. FQHC's patient navigators and work like my own in the community are part of the glue that keeps underserved communities from falling through the cracks. We are from the community, so we know firsthand, and we can talk to them in ways that allow them to be more open and tell us about their needs and start them on the road to a better health. We truly are the trusted messengers in the community, and I hope the council will continue to advocate for the resources needed to meet this challenge. I thank you for your time, and as our motto goes, at BMS, you come first, we make it easy.
Thank you so much for your testimony. We will now turn to our final panelist, Erin Verrier. You may begin once the sergeant cues you.
Time starts.
Erin, you still on mute?
Okay, unmute. Okay, great.
You're good.
Hi, everyone. Thank you, Chairperson Narcisse and members of the Committee on Hospitals for the opportunity to speak today. My name is Erin Verrier, and I manage policy and external affairs for Community Healthcare Network, a network of 14 federally qualified health centers in New York City. Our care is comprehensive and affordable. It's primary care, mental health, social services for up to 85,000 New Yorkers annually. Those we serve often have inequitable access to health care, but we provide care regardless of a patient's ability to pay, regardless of their immigration status, race, religion, ethnicity, gender identity, sexual orientation, all of it. We turn no one away. I want to send a special thanks to council members Charles Barron, Jennifer Gutierrez, and Rita Joseph for serving the East New York, Williamsburg, and Crown Heights communities where CHN has operated health centers for decades. Like you, we're really striving to increase access to high quality healthcare. In certain locations, we're filling the gaps in places where Health in Hospitals primary care centers can be hard to reach. I want to quickly highlight what we did in response to the pandemic. We stayed open for in-person visits. We pivoted immediately to telehealth as well. In 2021, 50% of our visits were conducted via telehealth. No-show rates dropped, especially for behavioral health, and patients could be consistent with their care. We also did big things for COVID testing and vaccination. We hosted over 85 pop-up events for vaccines with community partners like churches surrounding the health centers where our communities are. We administered over 30,000 vaccines, not just for our patients, but for their neighbors. I want to reiterate how comprehensive our primary care is. Of course, we provide general preventive care for individuals of all ages, But we also provide unique primary care services like dentistry, podiatry, nutrition. We do targeted outreach and customized programs to support health and mental health of LGBTQ populations. Nevertheless, beyond our doors, it can be hard to refer patients to specialty providers like dermatology and cardiology and keep track of their care. Today, we ask the Committee on Hospitals to develop and reinforce referral networks between hospitals and primary care centers like CHN. We want a closed loop process of care and need data and outcomes from specialty care providers to be shared across platforms so that we can track and follow up accordingly. Another area that is a real challenge to address that has been mentioned are the social determinants of health. As a provider, we're primed to respond to these and partner with local organizations. A primary one that we work to address is housing insecurity. Here's an example of how we respond. We partner with affordable housing developers. And when these developers have the opportunities to build a new site, we've been invited to co-locate and rebuild a health center of ours, expand its square footage and the services we can provide from the ground floor. Case in point, we're opening a health center called the Tree of Life, in a building called the Tree of Life, and expand our Jamaica Health Center. There will be 160 units of affordable housing, and we will get 15,000 square feet of health center space.
Time.
Looking ahead to expand the promise of our work, we encourage the following. One, to push for and strengthen referral networks between primary care and specialty services. Two, push hospitals to be active partners with primary care providers towards social determinants of health. And three, champion the implementation of Intro 6068. Let's get FQHCs and the NYC Cares Network and implement the program that has been proposed. I appreciate you having me here today and look forward to working with you. Thank you.
Thank you so much for your testimony. I will shortly turn it back over to the chair for questions. I just wanted to remind other council members that if you have questions for this panel, to please use the Zoom raise hand function. So again, if you're a council member with questions, please use the Zoom raise hand function. So thanks, and I'm going to turn it to the chair for any questions.
Thank you, Em. What role have community health centers played in providing care to COVID patients during this pandemic? And second question, I appreciate all the things because I know BMS. I know where you're located. And you're providing care to the most needed folks in our community. So continuing with that, what have you learned from serving the community that most vulnerable during the height of this pandemic?
I learned that you definitely have to meet everybody where they are. Be open and be willing to listen to all of their needs. Definitely never judge, and be very resourceful. And I'm very grateful for community partners because we do serve the Brownsville Eastern New York community. And I'm very grateful for all the other community partners who help us resource the families that are in need as well.
If I can also add, I mean, I think one of the things that we've really seen with health centers is how much they've been able to adapt to meet the needs and how they've been able to step up, how they were quickly able to provide telehealth, as you heard, to connect people with, to meet their social needs, to provide food when that was needed. So really, we saw that the health centers were really creative and innovative and able to adapt to meet the health center's needs, and really pleased with the way that they were integrated into their communities and were trusted, because I think for all of the health centers, certainly BMS, but all the health centers are known and trusted in their communities. And that was so important in terms of being a resource for vaccinations, where there was a lot of communities where that, there was an issue, a lot of questions about vaccinations and a lot of concerns. And so the people in the community knew they could go to the health center and ask those questions, and they trusted the health center to give them the information that they really needed.
And Max, next question can be for anyone. What you can share with us, what's some of your recommendation that how the city can do better to promote access to primary care?
Erin, you mentioned the New York City Care Act, the New York City Care Program.
Yes,
Do you want
yes. We really want FQHCs to be a part of the NYC Care program. So, we're here and ready to become involved in that, and think that adding FQHCs into the mix can automatically increase access to healthcare providers in New York City. Oh, I think you're on mute, Councilmember Narcisse.
Sorry. Yeah, I hear your recommendations on improving access to telehealth. How do we ensure that telehealth medicine is equitable, reaching communities that have limited digital literacy and seniors, most importantly to me, the seniors?
Well, one thing that we think is really important is ensuring that there's payment for telephonic care delivery, because especially for people who don't have broadband access, or for people who aren't able to navigate technology, that may be seniors, that may be other people, that having that telephonic access is something that's really important, especially for behavioral health, as we've talked about. So that's certainly something that we think is important. And then I think recognizing the costs of telehealth. It's not any less expensive. Really, the biggest cost for healthcare delivery is staff, is the human part of the care delivery, which is integral regardless of how care is being delivered or where. So those costs really need to be recognized and ensure that there's reimbursement for them.
Do you have any further comments or recommendation regarding the integration of CHACs into NYC Care?
We'd like to see community health centers included in the New York City Care program, and to see some funding that would allow for that. And we think that that's a really has a lot of promise, that model.
Oh,
all I can say is thank you. I appreciate your time, and you're doing wonderful work. And as a nurse for 30 years, I appreciate all the healthcare providers, the work that you've been doing, keeping our community going. So thank you, and I will pass it on to Em.
Thank you, and thank you for all your support.
Thank you.
Thanks so much to this panel. I don't see any other questions from council members at this time. And so what I will now do is ask if there, if I had inadvertently missed anyone that had registered to testify today and is yet to be called, if they could please use the Zoom raise hand function now, and you will be called on in the order in which your hand has been raised. Great, so seeing none, I will now turn over to Chair Narcisse for closing remarks, because this has concluded our public testimony. So Chair Narcisse, you may begin when you're ready.
I would like to thank all the participants in today's hearing. Wonderful moderator, what can I say? And policy analyst M. Balkan, that keeping me going. Thank you. I have to thank my Sergeant at Arms, Biondo, thank you. Sergeant Perez, thank you. Committee Counsel Habani Awuja, thank you. Finance Analyst Lauren Hart, thank you. All the CM that's there, CM Schulman, thank you. CM Barron, thank you. CM Joseph, thank you. CM Uterus, thank you. Brooks, Power, thank you. Rivera, thank you. CM Moya, thank you. I appreciate you for keeping up with me, and that's my first, and I'm loving it. I didn't have to keep it for longer than that. We're doing amazing, and I have learned so much. The members of the administration, Dr. Andrew Wallach, and Ambulatory Care Chief Medical Officer, Dr. Justin Lees, Assistant VP of Ambulatory Care, and Dr. Jonathan Jimenez, Senior Director of NYC Care, Rose Duran, Francine Cutler, and Erin Verrier. Thank you. I hope I don't butcher the name. Thank you. Appreciate you. I appreciate you all taking the time out of your busy schedules to have your voice heard on this vital issue, which requires our immediate and sustained attention. As a nurse for 30 years and now a member of City Council, this is an issue very near to my heart. As such, I look forward to continuing our dialogue and working together to close the health equity gaps that continue to negatively affect so many New Yorkers. I sincerely appreciate you and thank you all for joining us. Let's get the work done. I'm ready. Thank you. I'll pass it on to my end. So moderator M.
Councilmember, we are ready to conclude. You just have to gavel out.
Thank you.
Thanks so much.